I'm Dr. Preston Parry. This is First Friday Fertility. Welcome. I'm going to be talking about really important topic that's underappreciated and needs more awareness, which is pregnancy loss, recurrent miscarriage, and the variations that are there. This is something that is devastating. So one of the things you'll see for me, I'm not a profane person by any stretch of the imagination. Whenever there is a miscarriage, I think that if you don't believe in profanity, I would say that's the one time where it's appropriate, because there is nothing worse, nothing harder than you've had all this hope and everything channeled into bringing this child into the world, and then it's taken away. And so we're going to talk on the issues surrounding recurrent miscarriage. We're going to talk about also just single pregnancy loss. We're going to talk about a lot of the variations, what they are, what do you do to test for them so that you can see what sources are there, and potentially even what can you do to treat things. So incredibly important topic. And again, October is Pregnancy Loss and Recurrent Miscarriage Awareness Month, and so this is a timely topic, and it affects so many wonderful people. What is recurrent pregnancy loss? Recurrent pregnancy loss is when a pregnancy doesn't go forward and it happens more than once. And that seems silly or redundant, but for instance, you'll look at some of the Royal College of OBGYN guidelines for the UK, and they say you have to have 3 losses. If you look at the American Society for Reproductive Medicine for representing the US, they're saying actually 2 losses is sufficient. And the reason that's important is also because if you're wanting a workup and you're submitting it to insurance, and it's only been 1 loss, they might not cover it, but with 2, they're supposed to. So also, how do you get benefits to cover your fertility, your testing, your addressing this issue? And they're varying guidelines. It's interesting, the British tend to, again, look often at 3 losses, while for the U.S. it's the 2, but also the U.S. says it has to be clinically recognized, where again things are viewed on ultrasound, or actually there's tissue that's found when people have a miscarriage. For the miscarriages, having tissue is very tough for people when they pass something, because sometimes actually the tissue can actually be, it can look like something, but actually it was just a blood clot that was shaped like the uterus or the vagina or things like that, and it looks like more than it actually was. Conversely, it can actually be a full loss. And so the ability to evaluate it properly matters for things. Now, what is the difference between biochemical and other pregnancy losses? First of all, I think nobody should be shaming and blaming. Nobody should be saying, oh, my loss is more important than yours. All people suffer in their own way, and I don't think we should be trying to validate. I do think there are important and meaningful differences among various forms of loss, but at the same time, what it means to the individual is individual, and everyone should be respected in that. Biochemicals, though, usually refer to a loss that's so early you can't clinically recognize it. Now, there was a study done in the 80s in California, and they did daily urine pregnancy tests for these women who worked in a plastics company. And they thought they were going to have more birth defects and all kinds of problems. And so they tested everyone in the plant, whether you were administrative or a work at the floor. And what they found was the plastics didn't really have any bad effects that would have, led to problems. But what they did find with the study is women were pregnant a lot more than they realized. And so instead of a classic rate of 20% for miscarriage, if you do daily urine pregnancy tests, it can be 40%. That gap between the 20 and 40% is, where those biochemicals are, the clinically recognized pregnancies on ultrasound and those that will pass tissue versus those that are earlier. But actually, this is why they refer to biochemicals in a separate breath. If you're with an OBGYN, they will say a person has never been pregnant but has had 2 biochemicals, which seems counterintuitive. But because the biochemicals don't have the same negative predictive value as later losses, that's why the biochemicals under the U.S. guidelines don't usually count towards recurrent miscarriage. So they can be very meaningful and real to people, but you should also know that if you've had a biochemical, it's not as likely to result in future problems. Now, that being said, if you look at those biochemicals, where instead of 20% loss, it's 40%. If you look at IVF from the moment of fertilization, you can even see losses of not just 40%, but even 60 or higher. And a lot of that relates to DNA abnormalities. When we test embryos, you take embryos that failed to develop, and you take whatever cells are there, and again, they're just going to dissolve or break down, and you decide to test them, you will find incredibly high rates of chromosomal abnormalities that didn't make it to even the place where they could implant or attach or even grow for a bit. For instance, in a miscarriage, when they've tested the DNA, they've never seen trisomy 1. The chromosomes, 22 chromosomes plus X and Y, they're lined up from largest, number 1, to smallest, 22, and then the sex chromosomes of X and Y. And the larger the chromosome, the more earlier the more DNA, and then if there's a duplication, there's more mistakes. Triplicate for trisomy 1, has so many mistakes that basically it's incompatible with developing ever to the point it's clinically recognized. But if you're testing early, you can find these. And so there's a lot that's found within the DNA the earlier you look on. And so if you really are trying to understand why you're having losses, people say 50% at least of recurrent miscarriage is attributable to DNA. And some people say 60, 70, 80 or, for things. And the reason is that a lot of the chromosomal abnormalities that are there can't be detected with modern technology, particularly if you're biopsying an embryo. I always say to people, PGT, where you biopsy the embryo, it's like looking at a book. It'll tell you a chapter is missing, a page, a paragraph. Can't tell you a sentence, word, or letter is missing. So for PGT, where you look at embryos for whether they take or not, there are chromosomal abnormalities that are below what modern science can detect. And the reason is, if you take 6 cells from an embryo, and that's 12 strands of DNA, and you amplify that to 1 billion or more copies, some mistakes are made along the way. And also, you can only get a certain size where you can pick it up. And so this is some of the limits to where people test embryos with PGT, and that's why PGT-A, which is for aneuploidy or abnormal chromosomes, it's not perfect. So, number one reason, if you are having recurrent miscarriages, that's often from chromosomal abnormalities. Now, there are a couple other things, about 7 other things that are core for it. First, beyond DNA, the next thing people talk about is lupus. I've been surprised by how rarely I see lupus as a sort. It's supposed to be, or actually I'd say, sorry, that's number 3. Number 2 is anatomy. Anatomy I do see a lot, and I find people with fibroids, and I find people with uterine septae, where the fibroid is an outgrowth of the muscle. The septae is where the uterus starts off as 2 halves by the kidney, comes together, fuses in the midline, and resorbs to form a single cavity. Well, sometimes there's an indentation at the top, and it makes it hard for a pregnancy to attach if it implants on that midline septum. And that's because it doesn't have the normal blood supply, and also the baby can sometimes run out of room with a divided cavity. Most people believe you should remove a septum if there's been a recurrent miscarriage. I think there was a study called the TRUST trial, which created some controversy, but many of us believe the TRUST trial was done poorly, and we would rather rely on other research, because we just think that even though a randomized controlled trial is supposed to be the gold standard, we think that it was not done well, and as a result, the results are misleading. And so most of us are not relying on the TRUST trial to guide the management of the septum. But again, there are things that are out there. You can have, again, the fibroids. You can have scarring in the uterus, Asherman's. In fact, I've seen people with a lot of DNCs, and then not only was it the DNC that they've had the miscarriages before, but then the DNC led to scarring and fusion of the uterus, where then things don't want to grow. So that's also another reason. So there are a lot of things that with anatomy you can pick up. Again, ultrasound can pick up many things. I personally find hysteroscopy to give me a lot clearer picture than sometimes I get for ultrasound for the inner uterus, though there are some people who do well with 3D ultrasound and other approaches. But again, we found if you use a small fiber optic camera the dimension of a coffee straw, again, small enough to go in the male bladder in the office without anesthesia, you can have a lot of things that were easily missed picked up with hysteroscopy. We even find retained products of conception. A person who's at a loss, 6 months later you go in and you find they still have some retained placenta, and that necrotic or dead tissue is inflaming things in the area, which may be something of a source for why things aren't progressing afterwards. So anatomy is number 2 after DNA. Number 3 relates to lupus. I can tell you, and this is surprising because you see it more with people with autoimmune disease, you see it with high African American populations, and yet I've seen far less frequently lupus as source. It's supposed to be 10%. I would say for my practice it's probably somewhere in the 2 to 5%. So I'm surprised it's lower than the statistics. I have a degree of suspicion for it, but I haven't seen the classic numbers necessarily play out for lupus the way people have said. Number 4 is endometritis. This is something I also see a higher level of. Endometritis is an infection of the lining of the uterus. By the way, many people confuse it with endometriosis. Endometriosis is when the lining of the uterus is somewhere in the pelvis. It can even get into the nose. People can have nosebleeds when they have their periods. It can get all kinds of strange places, but generally it's in the abdomen or the pelvis. And but I'm not talking endometriosis, I'm talking endometritis. So you think of tonsillitis, appendicitis, it means inflammation. And you can find these little finger-like projections that are in the uterine cavity, and they reflect an inflammatory state. And supposedly, if you treat that, you can quadruple pregnancy rates by some studies, others less. And usually it takes 2 weeks of doxycycline. Now some people may be more resistant, you have to give different antibiotics, but the single best study I'm aware of showed that 94% of women responded to a single course of doxycycline. And by the way, if you get this inflammation and infection, this is not an STD. Don't think, oh my gosh, I have an infection in my uterus that my husband gave it to me, therefore he is in a lot of trouble and I'm seeking an attorney. Endometritis is bacteria that can be normally within the vagina without a sexually transmitted infection and then make their way into the uterus, which we thought was sterile, but for many women it is not. So this is just something to be aware of. Now again, if your spouse gives you an STD, definitely follow that through, but I'm just saying endometritis is not one. So that's the number 4 reason. Number 5 also relates to DNA, but rather than the random DNA that's unique to each egg or sperm, and remember, you see higher rates of miscarriage when you are older. You can see again, 10-15% of miscarriages in your late 20s, and then that ends up being, you can be 30% in your late 30s, 40% in your 40s, or even more. Some people in the 40s can even get as high as 80% of pregnancies miscarrying. So, as well as high rates of Down syndrome and other things relating to chromosomal shifts. So the DNA matters and age affects that. The next question is, if I'm having a miscarriage, let me finish off the causes and then I'll come back to it. Number 5 is, again, those rearrangements of the DNA, and this is called reciprocal or Robertsonian translocations, where part of one DNA got on another strand and part of that strand got on the other. So like you got, chocolate in my peanut butter, you got peanut butter in my chocolate, things swap around for things, and it leads to a lot of the DNA being imbalanced, and you have higher rates of miscarriage because about half of pregnancies, or sometimes even 2/3, can be imbalanced for when people try to reproduce. So that's very important. But usually for that, by the way, a lot of people, when they're doing chromosomal testing, they're looking for these types of things. Here's the thing. A lot of people want to do DNA testing when you've had a miscarriage. If they're testing the pregnancy or the products of conception, which are obtained often at D&C, that's usually looking, that it's more likely to pick up individual egg and sperm mutations. Although it can pick up the balanced translocations, but you need a lot of samples to know that it's there. If you're looking for just the balanced translocations, this number 5 reason, That's where they're usually testing the mom and the dad, or the source of the DNA, really for whether there's rearrangements. I usually tend to lean away from that. It's not that I can't, but here's why I lean from it. A lot of people pay $1,000 or $2,000 for that testing. If the testing is negative, you wasted that $1,000 to $2,000. If it's positive, then you'd have to do IVF, and then you'd use that $1,000 or two, you'd then have to figure things out. So for many people, I say there can be information doing that type of testing, but I usually say, look, if you're going so far that you would have to do IVF if you found something, then save that $2,000 for the IVF to figure it out. There are little advantages, because then you can look in some special ways to see if the embryos individually would have the likelihood of passing this on. But generally, I look at economics, and I'm trying to save people money. And so I would say, if you're testing the parents for the sperm and the egg, usually it's a little more economical to save that money in ways. So talk to a specialist if you think that's the right fit. Similarly, if you're testing the miscarriage itself, if the majority of the time it was chromosomally abnormal, then if you knew that on the front end, then the testing doesn't really help. And if you're saying, well, it came back as chromosomally normal, but sometimes it missed the abnormality, so it could have still been abnormal, you haven't entirely helped yourself for things. So I do worry sometimes people spend a lot of money. Again, there are other ways of looking at this. There are different ways of painting with a brush, but there may be more economical ways of working up a recurrent miscarriage state. So talk with your clinician about that. So that's number 5. Number 6 relates to thyroid disease. What's going to be, I won't say much on that, but I would say that a lot of us have been using a cutoff between 2.5 and 4 for your TSH. That's probably going to be softened in the coming years, and we'll be moving back to 4. As someone who's more strict on that 2.5 for most of my career, I'm admitting this is a seismic shift, but I think there's emerging data that out of the world's literature, about 8% of the literature can't be replicated, and 16% of the literature was actually faked, or their academic integrity is in question, where it's just not trusted. And when you remove 24% of the world's literature, and a lot of that stuff which people believe was faked or had some meaningful problems, when you remove that, it shows that being aggressive on the thyroid doesn't have nearly as much benefit as we once thought. That's changing our thinking. And so I think a lot of people who have been on thyroid medication, they'll debate whether they should continue. But I think that's something, again, as with all this, talk with your clinician. I always say, I'm giving general medical information here. You have anyone watching this, and wanting to apply it to themselves or a friend, you have to talk with a clinician for anything and everything, because not everything applies and the knowledge can evolve. So you have to have it individualized rather than just simply take the general. So that's the thyroid. Number 7 is diabetes. Boy, do we see a lot of issues for diabetes causing birth defects, causing problems. This is one of the interesting things. Obesity is associated with miscarriages, but there's question as to how much it impacts beyond that, relating to insulin resistance, diabetes, other issues. And so I think this is for concern and for debate. But if you are overweight and saying, did this cause my miscarriage, I think that's sometimes harder to prove than we think it is. And certainly, again, a lot of the people pointing the finger and says, oh, you miscarried because of your weight. I think you walk into a fast food restaurant and you'll see all these people eating horribly, and they're surrounded by a litter of kids. This is not an all or nothing thing, and I don't think we need the guilt and the shame and the blame that so many people do. What I would say, though, on this is try to be well. Whether just weight without diabetes affects outcomes has more debate than we think. But I would say you certainly want to avoid gestational diabetes. You want to avoid preeclampsia. You want to avoid stuck shoulders or shoulder dystocia for how the fat is distributed on the body of a child. You want to decrease the risk for death. So be well, but also don't take as much on yourself. And by the way, this is as an important side for this. Anyone suffering with miscarriages, for things like that, you're not alone. get support. As soon as people start talking about their miscarriages, people are hesitant to for fear of others' reaction, especially when they're already so appropriately sensitive to what the struggles they've been through. But you'll find that you're not alone, and so many people have gone through it. More than that, there are psychologists and specialists who can do a lot to support you. Really, do not suffer in silence on these things. These are so important. But anyway, the diabetes is another issue, again, that you should get testing for to avoid a lot of these adverse outcomes. And then finally, for the eighth thing that we see a lot of is prolactin. I used to believe that, for prolactin testing, you'd have discharge of milk from both breasts. And when actually only a third of those with high prolactin actually have that. Now there's debate whether those who don't are sort of low enough level that that's really not going to drive some fertility or miscarriage. So I still think there's some controversy with it. But I think we're evolving to a point where we test more for prolactin than we used to for things. Other things beyond those core 8, I think as you look for the sperm, that the older the father gets, the source of the sperm, source for DNA, you would say that that's more likely to have miscarriages. I think, again, we talked about age for women as an effect. We look for the ovaries, again, ovarian age certainly matters, and there's a lot of debate. If my eggs are fewer than I would expect for my biologic age, would that lead to more miscarriage and subfertility? It's kind of interesting. There have been a few studies on this recently. They show that if you're in the bottom 25%, that doesn't necessarily mean fewer eggs means you're going to have more chromosomally abnormal embryos. But there was a study that if you were in the bottom 10%, you did. And so I think we're going to continue to debate that, but I would say the worse the eggs are for quantity, the more likely there is an issue for quality. And again, not universal, but the more probable, so certainly paying attention to that. And certainly if you are markedly diminishing bottom 1%, ovarian failure, that's one where it's very hard to get eggs, and many people talk about use of an egg donor. And then the risk for miscarriage is typically that of the 25 egg donor, not that of the 45-year-old woman using the egg donor, providing there aren't uterine issues. So it's sort of the eggs. The tubes are rarely a source of recurrent miscarriage, although you can have a hydrosalpinx, which is a dilated, damaged tube. And that has toxic fluid and can leak into the uterus, so you want your OBGYN or fertility doctor to be looking at these to see if there's a problem. The uterus, all the things I talked about, I can give a whole list about this long for various things for the uterus that can go awry, that can negatively affect fertility. It's interesting that for polyps, we're a little less impressed with polyps, but fibroids we need better studies, but there are some studies showing a higher rate of loss for fibroids. I think fibroids are just complex. Number, size, and location all matter, and you can have multiple fibroids that are large, but they're in a fine location. They aren't going to have a negative effect. Conversely, you can have one really small one in just the wrong location, and that can be negative. So I do think appropriate evaluation matters for these things. Beyond uterine factors, when you look to systemic disease, this gets a little bit complicated. Certainly, having a lot of inflammatory conditions doesn't help. And so watching for that, I would say for lifestyle, alcohol consumption, smoking, excessive caffeine. People usually talk over 200 milligrams a day. Again, if you are homebrew, you get about 20 ounces of homebrew. Usually that's in the 200 milligrams or other or under. But if you go to a coffee joint, you get that skinny double half-calf mocha almond honey vinaigrette venti latte, you're often getting 400 milligrams in there. You're getting twice the amount you need. That can be very negative. So caffeine, I think there are studies that have shown even for chromosomally normal embryos are more likely to miscarry with high rates of caffeine, or there's disproportionately more normal ones in the losses for people with high caffeine intake relative to low. So this is one of those things where being mindful. Again, if I tried to take my wife's coffee away from her in a French press, she probably would have killed me, and then she would have been a single mom or not conceiving. But so there are limits to what you can do for caffeine. And remember, with pregnancy, your peak for caffeine is twice as high and lasting twice as long. So you do have to be mindful that caffeine has different levels within pregnancy itself. Smoking, again, prematurely ages the ovary, and so that's very important. Plus, of course, has many effects on preeclampsia, other issues. So obviously, definitely being mindful of that. A lot of the other things, pesticide exposure, radiation exposure, gases, very exposed to gases. I think we do want a cleaner environment. I don't think some of those links are quite as clear as we wish they would be. So certainly being mindful and being well, but I don't think that the fact that you walked through a busy downtown and inhaled all these car fumes one time, is going to make or break you, or at least I hope not, but I would say the data isn't nearly as strong on that front. Similarly, if you're working in a job where you're exposed to radiation, have the proper lead shielding. If you're exposed to gases, obviously, hairdressers, I talk to them, try to be in well-ventilated areas, but the data is actually a lot of hairdressers, a lot of anesthesiologists actually do quite well. So I think it's important to also say that there are many people who do fine. This is starting to get into another issue. What is the probability that if I've miscarried before, I'm going to miscarry again? And you usually say that the first, you're often 15 to 20% pregnancy. If you've never had a miscarriage before, if you've had one loss before, it can be 20%. As you start getting to 2 previous losses, you're often in a 30%, 3 previous losses, 40%. The numbers can vary, and it will also depend on age and reasons and other things like that. But generally, I think that's very important. Let's say you've had 1 loss and you're at 20%, and a friend said 2 losses and at 30%. That means the first had an 80% chance the next pregnancy would go well, and the second, the other, the 70% chance. They're still more likely than not still to do well. And I think there is still a lot of hope, even though there's a lot of fear, because you just care so much about the outcome. But the ability to say at least that, many people, even if you do nothing, will still do fine. Can give some comfort to some people, even though I would say, is there a way you can do some quick testing and leverage the odds more in your favor? Okay, next thing. If you're going to do a workup test, how do you do it? And I'm going to tell you what I do. And again, there are many other ways. Again, I always say I'm not going to teach the Leonardo da Vinci of recurrent pregnancy loss to paint with a different brush. I'm just saying what I like to do. DNA, first, you look at age. And the older the person is, the more likely there's a DNA issue. And you look at their antral follicle count on ultrasound. The antral follicle count, again, some people have quantity, some have quality, some have both, some have neither. But if I see a ton of eggs, and the person is at a reasonable age for things, the likelihood that there is an egg factor driving this isn't 0, but it's reassuring. And the fewer eggs I see, and especially if people are getting the bottom 5% or 1%, the more I'm worried that there's actually some meaningful egg issue going on. For sperm, advanced paternal age, I'm watching for that, and again, lifestyle as well. Those are very much in my mind. For looking at the uterus, again, I'll do for uterine factor, again, number 1 was DNA, number 2, uterine factors. I do a blend of ultrasound and hysteroscopy. And no study is perfect, but there's a lot that is picked up, and I routinely find things other clinicians have missed. When I do that testing, I think things are just so blatantly visible with hysteroscopy, and you get such small resolution that it's very hard for ultrasound at times. There's value. That being said, for ultrasound, I would also say that you have to look inside the muscle of the uterus. You have to look for adenomyosis, which I didn't mention is a glandular inflammation. There are all kinds of other things. So ultrasound has some meaningful value, and not just one test or another, but how it's applied. Lupus, I tend to do lupus testing more at 3 losses than 2, just so that I'm not, excessively imposing on people's insurance benefits for things. But if someone wants to get it worked up at 2 or 1 and run the risk of insurance not covering it, you have to give people options, and I'm supportive of that autonomy. But I generally just find that less frequently there. Endometritis, I'll often presumptively treat. I just say, you know what? If hysteroscopy picks up around 85% and a biopsy picks up 90%, but the biopsy costs a lot and hurts like heck, just treat with $30 worth of antibiotics instead of a $1,500 biopsy. I tend to be a little bit more on the economically efficient route for that and cover that base and get it checked off the list for most people. The balanced translocations, again, usually I'll save until people are doing IVF to look for rearrangements of DNA, but some people it's the right thing to test in advance, and happy to do so. Thyroid, diabetes, prolactin, 6, 7, 8, very easy to do on the front end, and so we'll often do those tests. For what you do for intervention for those, again, if it's a DNA issue, IVF with PGT for many people, where you find the chromosomally normal embryos and you stop putting back abnormal ones or allowing them to conceive with abnormal ones, that can go a long way in offsetting DNA-based sources. For the anatomy, you correct it, you remove fibroids, you remove septae, you remove scarring. For lupus, you would often do baby aspirin and Lovenox or an anticoagulant for things. I think there's, by the way, a lot of data that people used to turn to looking at things like prothrombin and factor V Leiden, and I think the field is really moving away from that. You'll still see it on the chat rooms and all these other things. A lot of docs still do those testing, but as you look to the more recent data, the prospective trials don't seem to show benefit from testing for or treating some of these other thrombophilias that don't relate to lupus. And so if you can create complexity, you're giving Lovenox, adding cost, but also if you're in a car accident, you're more likely to die. If you bleed internally, you could stir up bleeding by a healthy pregnancy leading to loss. If there isn't clear benefit and it can lead to complexity, I tend to stay away from that. But again, while respecting autonomy. But I would say, again, lupus is really the hypercoagulable state we're really watching for these days. And again, there can be some rare exceptions, rare patterns. Then for endometritis, again, presumptively treating. DNA rearrangements we talked about, again, rarely testing, just saving for IVF. Diabetes, prolactin, and what's it called? Repeating myself here. Diabetes, thyroid, and prolactin, screening for. And those are most of what you really need to look for. And again, for treating, as we were alluding to, treat endometritis with antibiotics. DNA rearrangements treated with IVF. Thyroid disease, give thyroid hormone, prolactin. You look for a growth in the brain called a prolactinoma. You treated that with cabergoline or bromocriptine. And again, diabetes, you treat their insulin resistance, help them lose weight, as well as give them insulin or metformin or other things like that. There are multiple solutions. I think one of the most important things that I've got to say about all of this is that it sounds complicated. I'm saying a lot. I'm talking a mile a minute, and I know I do. I always say to people, though, it doesn't matter if you have a fear of flying. What matters is if the pilot has a fear of flying. I think you don't have to memorize or remember everything that I've just said. What you have to do is say, we think about it, we're watching for it, and we will work on your behalf to help. And that's very important. And so come with your thoughts, come with your concerns, talk to us, another OBGYN, people in general, and get the support to help you get through the other side. Now, by the way, I'm talking a lot about losses that tend to be early. They're very meaningful losses for people that are later. And you will talk to people where the pregnancy had anencephaly, or the head did not fully develop for things, which is tragic and can happen to wonderful people. And the importance of folic acid for reducing neural tube or defects is often addressed in these settings. You can talk about, for instance, if people look for cervical insufficiency and the need for a cerclage. There's a lot of controversy that goes into it, and certainly a lot of people who deliver early also had an infection driving things, so you want to be mindful of those. But you can see even as many as 40% of people with delivery in the second trimester relating to a problem with the cervical strength. That's again, for debate. And usually a high-risk OB will be talking about that more than a fertility doctor, because usually for fertility, once you've gotten to the second trimester, you're cured and outside the window where many of us would intervene. But we still care, and we want to do whatever it takes to get people into a good spot. Other things that you look at for reasons for loss beyond cervical insufficiency issues, you can talk about molar pregnancies as a reason for loss, where actually people talk whether this was diaspermy, where two sperm enter an egg. There's some chromosomal abnormalities with molar pregnancy that are very rare and meaningful, and certainly you usually say that's unlikely to recur, and people talk 1 to 5%, but it's a low likelihood, so that's less likely to be recurrent loss, but it has to be addressed on its own terms, particularly because some molar pregnancies can become malignant. It's a gestational trophoblastic disease that is it can be malignant, so that's very important to address. And that can require also following HCG levels until it's been prolonged low. And some people use a cutoff at 6 months. There's been some softening of the lines from previously a year, and so definitely look into that if you're wanting information on those issues. And then people can talk about also, the other losses, embryonic losses where they never implanted. This is recurrent implantation failure. The embryos just never attached. And what's interesting is if you cover the DNA issues, a lot of the fertility issues, and a lot of the recurrent pregnancy loss issues, that picks up an enormous amount for recurrent implantation failure for people. And then there are other reasons. And I can go on a long list of those. Let's see, I just want to look at what people have said. Wait a minute, I've got a dashboard right here for things and seeing if there are comments here. Oh, hey, loving the things there. Hey, Hannah, for things like that. Do you suggest anyone to talk to when it comes to cervical insufficiency? Really good question there. And what I would say for it is to talk with your OB as to who they recommend. Some OBs are very comfortable in managing cervical insufficiency, placing cerclages. Others are not. Some people will have the maternal fetal medicine as a high-risk OB place it. And it's also, by the way, if you've had complexity for later losses, it's very good to talk to a maternal fetal medicine specialist for high-risk OB care. And so absolutely, talk with your generalist about that, or whether you'd be a candidate. One thing is, people have failed other cerclages, which is a way of sort of sewing the cervix closed. By the way, you want to keep a little bit of an opening so mucus can drain, because if it backs up, it can lead to infections. But sometimes people even do an abdominal cerclage, where it's to place higher and it's laparoscopic. And that's something that, again, it must be individualized, and you want to talk with people. Let's see, those are much of the things that are on my mind. And I think for all these talks, the reality is we want to give you information that helps you get where you need to be for your family, or friends, or anyone that's needing support. And I always say, as a rule, you can't fix what you don't know about. You tell us, we can address it, or others, but I'd say just don't go it alone. Whoever you reach out to, whatever you do, make sure you're getting the right support for the right thing. And thank you for tuning in. I hope, if you're on the journey, that you get where you want to be, and if you know someone who needs help, that they are. But good luck, God bless, and hoping to see a lot of wonderful children coming into this world for the rest of this year and next.